Good morning. I'm very excited that we have a quasi-live audience today, limited in social distancing, but more importantly, I'm particularly excited that we get an opportunity to share a little bit of our research, particularly here in Frisco and in sports medicine. We realized about 5 or 6 years ago that we spent a lot of time talking about our research, writing manuscripts, and even presenting on a national stage, and sometimes the people that work next to us in clinic don't always know everything that we're researching or everything that we're working on. So this is just an opportunity for us to highlight some of our favorite research projects over the last year, and hopefully we'll have some questions and engagement, and also maybe stimulate some other research questions. The best part about research is when you come up with a conclusion that leads you to 3 or 4 more questions. So I'd encourage you guys to take a look at it and maybe get some ideas of your own and let us know about it. We're lucky today to have a few people. We've got Ben Johnson, who's going to present a little bit on some research on the hip, Hannah Worrall on concussions, Sophia Ullman on some of her work in the movement science lab, as well as Chuck Wyatt, some of our work on cartilage in the knee as well. So these are all things we presented in the last year, so we're really proud of it, and again, encourage you guys to ask some questions. These are some of, this is some formalities because this is a CME talk, so these are some of our financial relationships. As you can see, we have no relationships and nothing that's really pertinent to this talk. I would encourage you guys, if you guys want to scan to sign in to receive your CMEs, please, you can do this with this QR code. The objectives here are to discuss the differences and early results of osteochondral allografting in the knee and skeletally mature and mature patients compared to osseous and non-osseous cam lesions. Maybe talk a little bit more about hip impingement in the hip. The use of the Pedi-FABS, which is the activity measure that we use to look at the activity measure in our youth athletes, and then discuss the differences in sports-related concussions that Hannah is going to talk to us about. I'd like to a little bit to brag on our research team. We have an amazing research team all over the entire hospital, and sometimes not everyone gets to know everyone really well, so I wanted everyone to know our research team here in Frisco. Claire and Madison are both interested in going to medical school. Madison's currently applying, and Claire will be in the next year. Hannah has really matured as kind of being one of the leaders on our campus. She certainly has the most experience and is becoming the go-to person for many of us. Diana Chen has done an amazing job with radiology and really pushing research along in radiology. And then we have an amazing movement science team that is continuing to do more and more things. And I think in the last 2 weeks, they've submitted 3 manuscripts, which is quite amazing. Here's our mission. Our mission really for research all over. For the sake of time, I'll let you guys read those, or if you guys want to watch it again and pause, you can. We've always had a research strategy, and we try to sit down and balance the research. We don't want one area to be overwhelming over another. So we try to balance multi-center collaboration, our basic science research, prospective studies, and retrospective studies. And if I really had to establish what I believe, it's probably important to spend 25% on each of these in terms of our time and our time management. So we really go through this and we make sure that not one of them is overwhelming the other, and we really focus on balancing it quite a bit. Early on, we got very overwhelmed with multi-center collaborations. You guys can see that right here. Now we've really determined a system to allow us to be a little bit more efficient with the ability to study multi-center collaboration. But as you guys can see here, there's well over a dozen multi-center collaborations that we're working on right now, some of which are new, some of which are old. We work through all of them, and we almost have a multi-center collaboration in almost every area in pediatric sports medicine, so we're quite proud of it. This allowed us to collaborate with our colleagues across the country, as well as produce good research. As you know, many of you guys know, in our basic science, we continue to work with some of our cadaveric anatomy. Dr. Wilson and I have spent quite a bit of time in Denver looking at pediatric cadaveric specimens, and also looking at OCD, Osteochondritis Dissecans, and we're really wanting to perhaps go into a little bit more about how we repair these and how we look at different types of healing models within the next year. These are some of our prospective studies looking at both the use of the unloader brace with OCD We spent a lot of time looking to return to play criteria with the ACL. My conversations with the physical therapy team, I would suspect that this is going to evolve within the next year as they're getting more and more engaged. We're going to continue to look at different pathologies in the hip, as well as one of our biggest projects is looking at pain management in the perioperative period. So we've done some preliminary pilot data on that. We hope to pursue that a little bit more seriously in the next year. And then Dr. Jones has really added a whole other area of research, which is utilization of the ultrasound in pediatric sports medicine, both with elbow injuries as well as perhaps looking at ankle injuries in the near future. And then retrospective projects, we've got big, large retrospective projects. These are a little bit, sometimes these are a little bit easier to do a retrospective review, but as we know, they're lower level of evidence. And so we have quite a bit of studies ongoing in all of these areas too. So just looking at our productivity, we've been busy. We're really proud of it. So we're excited, and we want to continue to promote a graph that looks similar to this. As you guys can see, in the last year, we really were able to produce quite a bit, and we really want this to change in the near future or to continue to grow. But it takes time, and it takes everyone in this room to really promote this research. So I really want to congratulate everyone here on making this a successful graph and a model. Just some highlights. Some of our collaborations have allowed us some awards, particularly at POSA this year. Best poster, best in trauma, and best e-poster they were all multi-center collaborations that we participated in. And then we also got top 5 finalists at SOCRA this year, both with our soccer sports participation and our pain management. So we're really proud of that as well. I'm going to quit talking and allow the people that we're going to present the real research come up here in just a bit. We're really excited about the future direction. Physical therapy is really exciting to get them involved in research and to expand that, as well as, like I said before, expanding into pain management and looking at Osteochondritis Dissecans as well. So we're really excited about future goals and management, particularly in the sports medicine department here. So I'm going to welcome Chuck Wyatt up here. He's going to give a first presentation. I'd encourage you guys to jot down some notes, ask some questions. You can be as basic or as advanced as you want them to, but this is interactive. Those of you guys that are joining us live, there's a chat box that you can ask questions, and there's an email that you can ask questions on. So please don't hesitate. We'll try to get to everyone's questions, but now's your opportunity to talk to us a little bit about our research in the last year. Chuck.
All right, thank you. Well, I'm Chuck Wyatt. I'm a pediatric nurse practitioner. I specialize in pediatric sports medicine as well as orthopedics. And today I'm going to present some of our research on osteochondral allografting for unsalvageable OCDs in the skeletally immature knee. And first of all, I'd like to thank my co-authors as well as Brianne Tassana, who's a rock star senior Parkland resident who's going into peds and hopefully on into pediatric sports medicine as well. And we did a comparative analysis of radiographic healing and early outcome measures between skeletally mature and skeletally immature patients. I have nothing to disclose. So Osteochondritis Dissecans, just very briefly, it's an idiopathic avascular event that occurs during development of epiphyseal cartilage's normal transition to the subchondral bone. And so with this red line here, I denoted the physis, and everything distal to that is the epiphysis. And so early on in development, the epiphysis, early on in development, the epiphysis doesn't have any calcified bone in it. It's all epiphyseal growing cartilage. And so what the pothole that we see there, it's not really a hole in the bone. What it is it's epiphyseal cartilage that failed to turn into hard calcified subchondral bone. We think OCDs are influenced by loading and by repetitive trauma. And so a little bit about management of OCDs. OCD management is based on the age of the patient. Early on, it's based on the age of the patient, the size of the lesion, and the stability of the lesion. Initial treatment, activity modifications, and unloader bracing is widely accepted as the initial treatment for stable OCD lesions. And then operative management, once we move into operative management, so they've failed conservative management, and it's based on the salvageability of the lesion. And salvageable lesions are managed with drilling, as in this picture on the left-hand picture, this represents transarticular drilling, which is where we drill across the cartilage into the lesion. We can also do retroarticular drilling with some recent studies. A recent good study out of the Rock group that was a randomized control study shows that transarticular drilling is probably better for stable OCDs. And then fixation with either screws or suture bridge. The suture bridge is kind of a new phenomenon that we're really excited about here at this institution, and have just recently put our series together. We think that the suture bridge offers the added benefit of not needing to go back for hardware removal when you fix an OCD. And so, but what I'm really here to talk about is unsalvageable OCD lesions, and kind of what do we do with these big, massive OCDs that aren't amenable to fixation or to drilling. And so we think fresh osteochondral allografts are the treatment of choice. There are other options available, such as like a Macy procedure, where they grow some cartilage cells in the lab, and you can then try to place them within the knee, the elbow, or the talus, or other things such as what we call sandwich grafting, which is biocomposite grafting, things like that. But we think the fresh osteochondral allograft probably offers the most benefits. And so this has been well studied in adults, but there's very little literature about fresh osteochondral allograft healing in adolescents. There's one series with out of the San Diego group that reported an 11% failure rate, but a 93% 5-year survival rate. So we decided we wanted to look. We do lots of osteochondral allografts here in our institution, so we decided that we wanted to take a look at our series. And so it's a single center series over 13 years. The inclusion criteria was that patients were less than 19 years of age when we did an OCA on them. We divided them into two groups. We had a skeletally immature group, which meant they had to have open physis at the time of treatment. And then we, as we narrowed it down, we only took OCDs. There were a couple of other osteochondral lesions, but we only looked at our OCDs. And the big thing with the inclusion criteria and why we lost some patients is that 12-month, you had to have a minimum 12-month of follow-up. In our outcomes, we looked at demographics, we looked at lesion characteristics, complications, reoperation. We defined graft failure as the need for revision osteochondral allografting, and we looked at radiographic incorporation, and then we looked at PROs. And so as we went down this path of looking at our series, we wanted to do a radiographic scoring kind of a system, and we looked, and there wasn't one. And so we created what I like to call the Tassano-Wilson radiographic scoring system for osteochondral allografts. We wanted to make it really, really simple. So it's A, B, C. A is complete healing. B is greater than 50% healing. C would be less than 50% healing, as you can see by these X-rays here. We try to keep it pretty simple. We did do inter and intra-related reliability studies, or a study on this, and looked at our kappa coefficient, and they were both really, really good. Also, big shout out to Amber O'Daughtry from radiology. She helped us quite a bit with doing that inter and intra-observer reliability portion of the study. It was fantastic, and props to our sector system is an amazing system. It allows us to anonymize things and to do that study, that part of the study pretty easily and pretty efficiently. So when we looked at all of our osteochondral allografts over that 13 years, we found 64 OCAs that we did. Of those, only 44 had 1 year, which is still pretty good. We like to think that we released a lot of these at 6 months, so we like to think that they did so well, we couldn't get them back. And so and then as we further broke them down, there were 44 knees that had 1 year follow-up. 37 of those were actually OCDs. 20 of them had open physis, and 17 of them had closed physis. Our groups were very, very similar. Except for, you can imagine with open physis, of course, these patients are going to be a little bit older. And there was a slight male predilection for open physis in our group. As far as the lesion characteristics, they were really, really big. They were very similar amongst groups, with the open physis group being 4.7 centimeters squared, and the closed physis being 5.2 centimeters squared. The only thing that was significant was that the medial femoral condyle was a predominant lesion in the closed physis group. A lot of these patients had contralateral lesions. So again, just kind of noting that our groups were very similar. And so this is a really complicated pathology when we're talking about big, huge osteochondral or big OCDs. And so a lot of these patients had prior surgery. They were the same across groups. Most of this was related to their OCD itself. With 42% of them having had a prior knee scope, with 30% of those having had attempted at healing. Some of these kids underwent realignment procedures, and two had prior osteochondral allograft treatments. There were some reoperations that happened. Most of these were planned for hardware removal, as much as 40% of these. And there were a couple of unplanned procedures, and those were within the closed physis group where we had two osteochondral allografts that did not heal. And then we looked at radiographic incorporation, and we compared the two groups. And remember, A is complete healing, and B is approximately 50 or greater than 50% healing, and C was less than 50% healing. And so we saw with the open physis group that the majority of those had complete healing of their allograft, whereas in the closed physis group we still had really good healing, which we considered was acceptable, with type B lesions being or type B grade of healing being being the majority of the closed physis group. But we considered both A and B as to be acceptable. When we looked at their patient-reported outcomes, both groups did really, really well, and both groups had improved patient-reported outcomes, both with the COOS and the Pedi-Acc ADC, as well as with the Pedi-FABS. When we looked at the PROs based on maturity, we found that the Skeletally Immature group had higher COOS quality of life scores than did the closed physis group. But what was really interesting was that when we looked at it by radiographic incorporation, it doesn't really seem to matter, or at least early on, other than their activity scales, whether or not we had acceptable or poor radiographic healings by our measurements. So I thought that was really interesting. But they do have the acceptable group, those with A or B did have higher Pedi-FABS scores and activity scales. And so in discussion, despite the immature epiphyseal anatomy, our study demonstrates that osteochondral allografts can be very successful in the immature knee. There were no graft failures, and overall complication rates were similar to other groups. It was associated with the open physis group was associated with improved radiographic scores, as well as graft incorporation, and improved and significantly better COOS patient-reported outcome measures than their older adolescents. And so in conclusion, fresh osteochondral allografts are good treatments and may be expected to yield good early results. And despite relatively large graft size, when indicated, patients with open physis have equivalent or improved healing, and patient-reported outcomes may be expected in the early term. And another thing too that I also think is an important part of the study is a lot of what I do is kind of dealing with insurance companies, and almost every time that we post a case for an osteochondral allograft in a skeletally immature patient, they try to tell us that it's not indicated in a skeletally immature patient. There's just not a lot of research that's there, so I can't wait till we get this published. It's going to give me some ammunition to help trying to get these surgeries authorized. Anyway, thank you for the references.
Does anyone have any questions? Was it one? Okay. Chuck, I got a question for you, just talking about the difference between radiographic healing and the patient-reported outcome measures.
Yes.
Do you think that there is a do you think that at longer-term follow-up that may be a more important consideration?
I absolutely do.
Is whether they heal radiographically and whether that's going to correlate with the patient-reported outcome measures? Because going back to the concept of treating the patient and not the X-ray, sometimes it's hard to do both because the X-rays may not look great, but the patient may be doing terrific. And how do you think this study helps us learn from that, or any thoughts on the future of it?
Well, I think that, as you said, I think the important thing is to treat the patient. Again, we're talking about radiographic outcomes, and it may be a better thing would be to look at MRI outcomes where we're looking or healing rates where we can look at the cartilage itself. And so I do think that we need to continue to look at this series and see how they do, how this older population does over time. But there may be some effect of the long period of time that they're out of sports, undergoing any kind of a procedure that allows their knee to settle down to a bit as well.
That's great. And I think there's a question.
Like the graft failure rate, like do the skeletally immature kids present earlier if their graft's going to fail versus like the skeletally mature, or is there kind of, in terms of like follow-up, like if they're going to fail, do you see them earlier in the mature kids and later in the...
We did look at that. The patients had a similar time to presentation. It may be back to the simple fact of kids heal better than adults, right? And if you look at the concept of thinking about OCDs as a non-union, right, as a fracture non-union, then that younger patients are probably going to do better than older patients. And I didn't get into this, but the younger group did have a few more realignment procedures. And so in the skeletally immature, we can do things like guided growth, whereas in the mature patients we got to do osteotomies, distal femur osteotomies, and high tibial osteotomies to unload the joint. And so so the skeletally immature patients, lended themselves a little bit more towards doing realignment procedures, and there may be an effect of that. But it was such a small percentage of the group that we couldn't look super deep into that.
That's great, Chuck. Thanks very much. I appreciate it. And
appreciate it.
Like Chuck had mentioned, it's a really exciting study. As there's just not a lot out there. It's a bad problem in the skeletally immature kid. It's rare, but it's a bad problem, and this is one of the very few out there looking at the skeletal immature kids. So we're excited about it. Next up is Ben Johnson. Look at some to talk about another study that we've had the opportunity to present this last year, looking at hip impingement in kids.
Yeah, thanks, Dr. Ellis. As he said, my name is Ben Johnson. I'm one of the PAs here in the sports medicine department. This is a project that we're really excited about. We've had the opportunity to present it at ISHA as well as AOSSM. It's been ongoing now for a little over a year. So we understand a lot about impingement, but hopefully we'll learn a little bit more this morning. So FAI is a clearly recognized, or I don't have anything to disclose. FAI is a well-recognized cause of potential hip pain in the adolescent. And it's thought to be related to an abnormal contour of the femoral head-neck junction, or in alterations in the acetabular morphology. The two types of impingement are labeled based upon the area of abnormal pathology, with CAM type being more the abnormal contour on the femoral head, and pincer type being the changes in the acetabular morphology. And there's also a third, probably more common type, which would be a mixed version and a combination of both of those. It's a clinical diagnosis, but these things should be correlated with diagnostic imaging. To kind of quantify femoroacetabular impingement, we utilize the alpha angle as described by Knotzley, which involves placing a perfect circle around what we hope is a perfectly spherical femoral head with a line bisecting the femoral neck. And the area in which the neck exits the circle, we will measure that angle. Traditionally, the alpha angle greater than 55 degrees would be well enough to establish the diagnosis of FAI. The first-line treatment for all patients diagnosed with this, whether it be adolescent or adults, is non-operative in the form of activity modifications, anti-inflammatories, and physical therapy. However, in the event that those fail, we typically would associate surgical intervention with alpha angles greater than 55 degrees in the adult population. But there's two clinical series, one out of Rush that was published in JPO in 2016, and another one out of NYU, which looked at outcomes, 2 to 5 year outcomes in the adolescent population, and demonstrated that actually their alpha angles were a little bit less than those that were being treated in the adult or skeletally mature population. And so there, like I said, the mean alpha angles was significantly less than 55 degrees. We proposed that maybe this might be due to more soft tissue type impingement that may not be evident on radiographs. We already know there's notable differences between adult and adolescent skeletal morphology, thickened chondral surface, thickened periosteum, and the presence of a perichondral ring. Here we have a picture, this is an arthroscopic image of a femoral head here, which you can see the presence of a soft cam or a non-osseous cam lesion that was identified in this patient. What we don't know is whether this is an isolated entity or a separate entity, or rather just the early stages of what we will eventually identify as a traditional osseous cam lesion. So the purpose of our study was to evaluate a case series of young patients with non-osseous FAI as identified on the femoral head-neck junction. And then also secondarily to compare those patients who underwent surgery for that with a cohort of patients with a traditional cam lesion associated with FAI. We performed a retrospective review of prospectively collected data in our global hip registry over about an 11-year period. We defined a non-osseous or soft cam lesion as a soft tissue prominence at the same location at the femoral head-neck junction. We reviewed just over 332 MRIs and reviewed every one of them for the presence of a soft cam lesion. Once these were identified, we had one of our fellowship-trained musculoskeletal radiologists further characterize the lesion and identify other associated internal derangement of the hip, such as labral tears. We measured the alpha angle on both the 45-degree done view or a frog leg lateral view, as well as the MRI, which was described in the technique previously mentioned. And then, as I previously mentioned on the other slide, we looked at the outcomes, the patient-reported outcomes for the osseous and non-osseous cam patients, looking at their modified Harris hip score as well as the hip osteoarthritis outcome score, or HOOS. We identified a total of 31 patients, which represented just less than 10% of the total cohort with a diagnosis of FAI, largely predominant females at 83% of the cohort, which were 16 years of age with a BMI of 23.7. These were no difference between the two groups. It was a largely active population with 87% involved in sports, and 80% of them were chronic in nature with an insidious onset of symptoms. Here are a couple of images of the T1 weighted images, which we feel like shows it the best in both the AP or coronal view as well as the axial view, demonstrating the different types of the non-osseous cam lesions. About 26% of these represented what we thought was consistent with periosteal thickening. The predominant 71% of these lesions were consistent with a thickened perichondral ring, and then really only one of those lesions was consistent with physeal extension. When looking at the alpha angles, the soft cam demonstrated a statistically significant difference between X-ray and MRI, with an average alpha angle of 51 degrees on the 45-degree done view and almost 63 degrees on the MRI. 71% of the patients that were identified as having a non-osseous cam lesion failed conservative treatment and eventually underwent operative intervention. And when comparing those patients to the cohort of the osseous cam lesions, it demonstrated no difference in age, sex, or BMI, sex or BMI. Interestingly enough, there was a significant difference in age at the time of surgery, with those with non-osseous cams being just about 1 year older, but similar presentation between the two groups. In regards to patient-reported outcomes, there was no significant difference in the modified Harris hip score or HOOS between both cohorts. So in conclusion, we know that FAI is a well-known cause of adolescent hip pain. We would encourage clinicians to be aware of the potential for non-osseous causes of femoroacetabular impingement, even in the absence or in the presence of a normal alpha angle on radiographs. We know that if those patients go on to surgical intervention, we know that those patients compared with not with traditional osseous cam lesions are comparable, and that further research is warranted to determine if this non-osseous or soft cam lesion is a separate entity, or if this is just where we see them in progression to a traditional or osseous cam. Thank you.
Any questions?
Hey Ben, how's it going? I was just curious, did you guys find a difference in the number, like between the two groups, on the type of sport that was played, or like certain demands?
Yeah, so we did look at that. Actually, about 70% of the cohort were dancers, which we're not sure if that is clinically relevant. We do see a large number that may be a little bit of a selection bias, just because we see a large dance population who happens to have a diagnosis of FAI. The actually next most common group was actually track. So a little bit different than what we would traditionally see as, you know, what we associate with a traditional or osseous cam. But as we continue to follow this group, we'll kind of try to identify whether or not that has anything to do with maybe this is a separate entity and those patients are participating in different sports, or if this is just truly a result of selection bias.
Any other questions? All right. Thanks, Ben. I appreciate it. Next up, we've got Hannah Worrall, who spent quite a bit of time looking at our concussion data, and as well as really being our liaison with context. And so she's going to talk about one of the studies we presented last year, and I'll let her introduce the study. Thanks, Hannah.
Thank you, Dr. Ellis. As he said, my name is Hannah Worrall, and I am one of our research coordinators here, and I'm going to be talking about one of our recent projects. Are there differences in concussion-related characteristics and return to play in soccer positions? I have nothing to disclose. This project does come from our context study, which is a registry of all of our concussions for patients who are over the age of 5, including adults who present to UT Southwestern, Scottish Rite, or Children's for Care, and then we follow these patients for about 3 months post-enrollment to look at outcomes related to their concussion. And this study is funded by a grant from the Texas Institute for Brain Injury and Repair at UT Southwestern Medical Center. So studies in American football have shown that there are differences in the risk of concussion based on player position. And as we all know, soccer here is a very popular sport worldwide, and soccer athletes, specifically females, have the second highest rate of sport-related concussions, only behind these football players. And so with this high incidence of concussion, it is important for us to determine if there is an increased risk in these athletes based on their soccer position. So therefore, the purpose of our study was to examine the injury-related characteristics and outcomes for differences among soccer positions following a sport-related concussion. So prospectively collected data on pediatric soccer players who were enrolled in our context study over about a 4.5-year period were reviewed. The concussion had to have occurred in an organized soccer event, and the player's position at the time of injury had to have been documented for them to be included. And then the variables from the study that we reviewed were demographics, medical history, concussion details, and then outcomes of symptom resolution, return to play rates, and then days to initiate the return to play protocol. So figure 1 here shows the 4 groups that the soccer players were separated into. We have forwards, midfielders, defenders, and then our goalkeepers. So in our study of 299 soccer players, we found that most of our concussions did occur in the midfield position, but more importantly to note is that 16.4% of them did occur in our goalkeepers. And when you look at the ratio of goalkeepers to all other positions, our goalkeepers only account for 1 out of 11, or 9.1% of all of the players on the field for a team. So we found no significant differences between the position groups in demographics, medical history, or injury characteristics, with the exception of a history of depression, where we found that our goalkeepers had the highest rate at 14.3%, and then also in the mechanism of injury, where our forwards, midfielders, and defenders either reported a head-to-surface or head-to-ball mechanism, while on the other hand, our goalkeepers were reporting more often a head-to-body part injury. So then looking at our outcomes at 3 months post-enrollment, we found no significant differences in prolonged symptom resolution or days to initiate the return to play protocol, but we did find a difference in the return to play rates, where our midfielders had the highest rate at 95%, but all of the other positions only reported their rates in the 80s. So while most of our positions did have similar characteristics and outcomes, we did find most of the differences amongst our goalkeepers, who again had the highest rate of depression, suffered more concussions based on the ratio of players, had a different mechanism of injury, and then also had the lowest rate of return to play at 3 months. And we hope that some of the results from this study may be able to aid our providers in educating parents and athletes in the risk of concussion based on soccer position, and may also play a future role in injury prevention, as in safely training our players in their positions. Here are my references. And then I'd also like to take this opportunity to thank my co-authors for their contribution to this study. Thank you.
Boy, that was a great review on a really important topic, which is mental health in our young athletes. Do you think that there's a role to start looking at soccer players as a whole in terms of their mental health, perhaps not associated with concussions, and trying to take a little bit more serious look at goalies versus other positions?
I personally do, based on this study. We do always try to get, as we noted here, a history of depression and anxiety. In some of our studies, we kind of have seen some differences sometimes in those patients when we look at their symptom scores and outcomes. And I think, as you mentioned, mental health does have a huge role in our athletes today and the pressure they're feeling. So I think this could be something that we continue to need to look at more importantly in our patients.
Does anyone else have any questions? One more question, and this may be a question for some of those who take care of those with concussions, but does a study like this, oftentimes, sometimes we're protocol driven, we don't want to be, but we should individualize our medicine. And so does this open up our eyes to think of perhaps being more considerate in looking at a soccer player with a concussion, taking it a step further and saying, oh wait, you're a goalie. Well, wait a second, because I know that goalies have a lower rate of return to play and goalies have higher rates of depression, should that be an automatic, we need you to be seen by a psychologist just to go through the process right now and to perhaps, individualize some of our treatment modalities based on position and player? I don't know if you have a comment on that, or?
I may turn that over to our providers.
Yeah, I don't know if it would be an automatic for everybody, but probably just help you screen, and I think that we are doing a better job of screening all of our athletes that come through, regardless of the position or sport that they play, because of the heightened awareness and certainly the impact of COVID and everything else on all of our teenagers. But I think probably having a lower threshold to intervene and make that referral early on, rather than waiting until we've dug ourselves a hole and are struggling and are behind in school and have not returned to our sport. And, sport is often a coping mechanism for those with mental health issues. And when we take that away as part of their treatment to protect them from further injury, sometimes we're causing some worsening of those symptoms and struggling and fighting against ourselves a little bit. So I think absolutely a heightened awareness and early intervention and screening is important.
All right, I'm gonna go ahead and start. Yes, so this is a little bit of a change of pace. This is a project we've been working on in movement science for over a year now, so something we're really excited about. And I'm only gonna go through a part of it. So we've been working to standardize a sports testing protocol specifically for motion capture labs. I have nothing to disclose. So motion capture technology has been used in youth sports, especially sports medicine, for quite a while now, but based on the patient population, based on the sport you're looking at, your studies are gonna look very different. Marker placement is gonna look different. The tasks you decide to use and look at are gonna look different. How you look at each of those tasks, whether you look at the first jump of a drop vertical jump or the descent phase of a single leg squat, that's gonna be different across the different studies. The model you use, which if you work with movement science, you know we love our models. So the model you use, and then if you use this type of testing for return to play, the rubric you use. It varies quite a lot throughout the biomechanics literature, which is why every biomechanics study you read is gonna be like 30, 20, maybe 40 kids. It's never gonna be your huge 100 to 200 kids in a study. Which is why we've been working to standardize a protocol that multiple labs can adopt. So hopefully we can, grow those sample sizes. I'm only gonna hit on one part of those different aspects. It's just the tasks today. So a group of us have been working to standardize this protocol, and we've decided on these 6 tasks. I'm not gonna go through all of them because I don't have the time. But there actually is a lot more that goes into each task. Everyone at all these different labs actually collect these tasks completely differently. And I'm gonna just pick one. Probably the most simple is the step down tap. It's an isolated single leg squat. You would think it's pretty simple, but as we were starting to talk with these other labs, we have about 6 core labs that are collaborating. Everyone does this task differently. Your platform height matters. It changes the kinematics. It's gonna be different for a taller patient versus a shorter patient, maybe more challenging, more easier, et cetera. Standing orientation, this was presented actually as a podium by Ashley at GCMAS. Whether you're doing the squat with the leg anterior to the body or lateral is gonna change kinematics quite a bit actually. How you look at the task, so where are you looking at the descent phase or the ascent phase, where you actually put those beginning and end time points is gonna change the variables that come out of the task. Arm and foot placement seem pretty simple, but they actually also change kinematics specifically of the trunk. This was also presented by Ashley. And then the instructions and corrections you give to the patient is greatly going to change. Not so much in the step down tap, but in the next example of the drop vertical jump. So if you're not familiar, the drop vertical jump, you start on a box, you jump off the box, land on a target, and then do a max vertical jump. The box distance that I'm gonna talk about is based on the subject's height, and it's the distance from the box to the landing target. So the drop jump, surprisingly, is the most common drop vertical jump we see in literature. So the box is directly behind the force plates. If you're familiar with Tim Hewitt or any of that group's literature, they do this type of task. Some people move the box a little bit back, so this is 1/3 of the subject's height distance from the target. Just because some groups think the half height distance is a little bit too challenging for some patient populations if they're not quite cleared to return to play. However, the half height is used in the LESS, landing error scoring system, which is used by PT. So at Scottish Rite, we like this condition because it's more relatable to what the providers use, but it varies quite a bit in the literature. So this is a perfect example of something we're trying to standardize in this sports testing protocol. So all these different labs that are doing these studies and reporting results are doing it the same way, because this changes hip and knee kinematics, which was actually presented by Alex and won Best Poster Award at GCMAS. So this is just an example. It changes the ground reaction forces that we get off of the force plates as well. Some other things that vary across studies is the use of a target and the instructions given. So the instructions of that first drop vertical jump, whether you drop off the box or maybe pop off the box, that we have found changes the asymmetry, which if you're looking at asymmetry between legs to clear an athlete to return to sport, pretty important variable there. So drop off the box we found through our data collection was actually quite confusing to some participants. And so another lab provided these modified instructions to bend your knees and slightly pop off the box. So there are quite a few things that we have to consider whenever standardizing this protocol, including the use of a target. We found the use of a target changed hip and knee flexion angles, as well as the knee varus valgus curve, which is one of the most important variables we look at, and the ground reaction forces. Okay, I'm not going to go through the last 4 tasks because it's quite extensive, but just to go over some things we are discussing as we're trying to standardize this protocol. So with the single leg hop, you want it to be a maximum hop, but you also need them to land in the force plate. So how do you determine their max distance and set that starting line? We have a certain way of doing it. Other labs have a different way of doing it. It matters. For the other tasks, we call it our run series, the run and cut, the lateral shuffle, the deceleration tasks. Where you put the cones, how you set up the task, how you instruct them to perform at their maximum effort is all going to change their natural mechanics. You want to elicit as natural mechanics as possible, but you also want to make sure they're trying their hardest so that you get the results that you're looking for. Something else to consider is lab space. We are very lucky here at Scottish Rite to have a 30-foot run-up to the force plates. Not all labs have this, and we do have to consider how that difference may cause difference in our outcome variables. So the vertical ground reaction force, which is what we use to calculate kinetics, so knee moment, the loading on the knee, that's going to be changed by how much distance they have to run up to the plate. Something very simple you wouldn't quite think about, but most labs only have 12 feet run-up space. So where are we now with this project? We've done quite a bit. I mentioned a couple of podiums and posters at the past 2 conferences. We also had a pre-course last January at PRISM that was quite popular, which led us to a tutorial at GCMAS where we kind of went over some of our preliminary findings. We're presenting on the marker placement, we're presenting on the tasks, the models, the outcomes, etc. So, and from these presentations, we had quite a few people reach out. There are a lot of motion capture labs across the nation who they have traditionally done gait analysis and they're looking to open up to sports and they're like, I don't know what marker set to use. I can't use necessarily the wands because they wobble, so what do I do? What tasks do I collect for a knee population versus a hip population? How do you use this data to make clinical decisions, etc.? So we have quite a few people interested in this work. And where are we going? So we just submitted a LOI to POSNA. I mentioned at the beginning this rubric here on the right. One of our collaborators is actually using this protocol already to make clinical decisions for return to play. However, it's a very preliminary rubric, and so we are hoping to actually conduct a study to optimize this. Some of our collaborating labs want to use the sports protocol testing to supplement what they're doing with PT. That's usually the more popular use. And then another thing we're doing is we have a survey out right now, and then we're also hoping to conduct focus groups at the next PRISM conference, just trying to get the provider perspective. We're working really hard to get this motion capture protocol for sports testing up and running, but if providers feel uncomfortable with it or if they don't think it's clinically useful, there's a barrier there that we need to figure out. So we're hoping to get more understanding of what providers want and what they need and what they're comfortable with. And this is definitely a team effort. So I mentioned a few times that this is, there are a lot of collaborators. This is a group that's been together for over a year now, and they're all they contribute quite a bit. So the movement science team here, Ashley, Alex, Dr. Tolchin Francis, and then a few other labs across the nation as well have all pitched in. Thank you.
Do we have any questions for Dr. Ullman?
Great presentation. Thanks, Sophia. Have you thought about giving a large stipend to the participants? I'm kidding. I was one of the participants. So, yeah. So you mentioned maybe some labs don't have the setup that others do. Would you recommend that they forgo a particular test if that was the case, or should they just adapt it as best as they can?
That's a good question. And first, thank you for participating. You were a participant, so I really appreciate it.
Of course.
So we've picked 6 tasks. We have found through this process that a lot of labs have tasks they're close to that they want to keep in. So we've picked 6 core tasks that they have to maintain, and then they can add more tasks to their protocol. And with those 6, they are all tasks that can be done in a very small, isolated space. Pretty much every lab you're going to have has at least 2 force plates because you have 2 legs, and everyone has at least 10 feet run-up space. So we've tried to make the protocol such that it fits any lab. Great question.
Thank you, Sophia. I appreciate
Yep,
it.
of course.
We're running a little short on time, but I do just want to mention one of our projects, and I'm just going to kind of highlight the punchlines in this project, looking at really a correlation between the PROMIS global health scores and a pediatric activity scale. I discussed this a little bit earlier, but it's a really important concept that we want to know, and that is that when someone says I'm an elite athlete, or I'm a collegiate athlete, or I'm a recreational athlete, it really helps us understand if we can put a number to it, because it really helps us understand how many hours are they training. Does someone who's training 30 hours a week, do they equal the same level of athlete if they're training 10 hours a week? Someone who travels on an elite team, are they the same as someone who is more of a regional or locally based team? And we don't really know those answers, but we want to learn more. And that does help with decision making when we talk to the family. And so we want to know, does this have a correlation with their general health? As we mentioned before, we have no financial disclosures. We know that regular physical activity is important in our youth. It's clear, it's established in the literature. Large databases have demonstrated that you have a lower risk of obesity, cardiovascular risk, metabolic risk. Does also say that it improves some intelligence, academic achievement, is to really have regular physical activity. So we know that it's important, and we also know that regular physical activity, or the trends of it when you are a youth, really carry with you into adults as well. And so some long-term studies have also demonstrated that. So the purpose is to evaluate the association between a validated youth activity scale. We use the HSS Pedi-FABS with the global health score PROMIS. Many of you guys know the PROMIS. It's PROMIS is a validated patient-reported outcome measure, and we use the general health. So we're just looking at the general health outcome in our clinic. As you can see, we standardize these questionnaires in clinic every time they come. Now, here at Scottish Rite, we've recently adapted that in Epic in our EMR, but we have been doing this here for about 5 years using a different software system. So we've been asking this question really since 2016, some of the validated PROs. And so we wanted to look at that and correlate it to their activity measure. The HSS Pedi-FAB really focuses on 8 components of activity. It's not really meant to be joint specific or disease specific or sports specific, but it looks at different types of movement and cutting maneuvers. And then the PROMIS, it has a total of 9 questions. The first 7 questions really focus on social, emotional health, quality of life, and then the last 2 questions really look at fatigue and pain interference. And I highlight those because we looked at that a little bit differently. In our series, we had 1,000 patients. Average age was about 14. In our patients that show up to our clinic, mean was 9.4 hours per week of participation in sports, majority of which are 30 weeks per year in their primary sport, which is great. And then most of them had been playing their primary sport for quite a while. What you can see here is the mean score on the Pedi-FABS is 19.7. The max score is 30 as a reference. And what you can see is there's a positive correlation with general health, but a negative correlation with fatigue and pain interference. And so this is really important. This suggests that the more active you are, the more emotional well-being, general health that you have. But there's an inverse, which means the less fatigue and pain interference. So this is really just an early glimpse of the importance of physical activity in our youth. We broke these up into bottom 25%, mid to bottom 25%, mid to high 25%, and the high 25%. As you can see, what you have is depending on how active you are, there was a direct correlation. It's kind of similar to the table beforehand, but you can see the more active you are, the better your general health is, the less your fatigue is, and the less your pain interference is. So, You know, this is really not new. It's not novel, but it's just another way to look at the data. We know that regular cardiovascular fitness improves the healthcare quality of life using another patient-reported outcome measure. This is the first one that I'm aware of that uses a promise. We do think there's some psychological considerations, as we know that some kids have less depression and less anxiety if they're involved in regular activities. And there are limitations, as there are with any study. So in conclusion, I'd say pediatric patients with the lowest activity level, according to HSS Pedi-FABS, reported the lowest PROMIS global health scores and the highest fatigue and pain interference. It's kind of the inverse of what I was saying, but it still is very, very, it's kind of the opposite of what I was saying, but it's still very, very true. The association between the association is clinically significant, as it suggests that higher childhood and adolescent activity measures is associated with improved global health, and really serves as a foundation for us to continue to understand more how physical activity can help improve the mental health of our youth. And obviously there's a balance, as we learn in all of these studies today, is the importance of mental health in our youth athletes. So this is just another way in which we're looking at it. So those are the references for the study. Well, thank you guys for coming today. Thank you guys for joining us online. Really encourage you guys to give us some feedback. We really just wanted to highlight some of our research over the last year. We're really quite proud of it. If anyone has any interest in something sparked an idea, they'd like to look at that idea differently, we'd love to participate. I'd say that this project with the Pedi-FABS is we have the data, and John Wagner and Connor Carpenter, who are now really in medical school, they were the first ones that said, hey, we want to look at this data a little bit more seriously. And they looked at it and they ran with it. And so we already have one publication from it, and we're hoping to have one more in the near future. So feel free to reach out to anyone on the research team. We're lucky to have such a great team. And thank you guys again for coming.